First, I'd like to thank you for your attendance, and thank you again in advance for your attention. This would be a very brief and simple presentation. I have to admit, as a surgeon, all the previous presentations were beyond the capacity of my understanding. I'd like to share with you our results with this simple study about the instance of level 1 cervical lymph node metastasis among patients with papillary thyroid carcinoma with involved level 2 lymph nodes. Papillary thyroid carcinoma is the most common cancer of the thyroid, accounting for about 80% of cases. And in 35 to 50% of patients, cervical lymph nodes will be involved. The lymphatic drainage of the thyroid gland is quite complex. There is intraglandular plexus that allows between the both lobes through the isthmus. And there is extraglandular spread, again, superomedial to the prelaryngeal lymph nodes, inferomedial to the tracheal, paratracheal lymph nodes, superior and inferolateral to the jugular lymph nodes. So there is a stepwise sequential fashion of lymphatic spread between both lobes and even down to the mediastinum. However, there are skip metastases in about 11 to 38% of cases. So what is the regional nomenclature of cervical lymph nodes? We have stage 1, which is 1A and B, stage the submental and submandibular lymph nodes, then the levels 2, 3, and 4 are the jugular, upper cervical, middle cervical, and lower cervical lymph nodes. Then the posterior triangle would be level 5, the central group would be level 6, and then the superior mediastinal would be level 7. The commonest is levels 3 and 4, and the least is level 1. So the commonest site of recurrence in cases of papillary thyroid carcinoma are the regional lymph nodes. The prognosis of papillary thyroid carcinoma is very good. However, some cases who are at high risk have poor prognosis. This depends on the gender. Male gender have worse prognosis. Age, above the age of 45, have worse prognosis. The size of the tumor, if it's more than 3 centimeters, if the tumor is multifocal, and if there has been spread beyond the thyroid gland, all these make the patient at high risk. So does modified radical neck dissection improve the prognosis in terms of reduction of the local recurrence, or is it only for positive lymph nodes? The 20-year survival rate in high-risk patients is high. There is a debate about the extent of surgery of the cervical lymph nodes in papillary thyroid carcinoma regarding level 1, which is the submental and the submandibular lymph nodes. Should we remove these lymph nodes from the neck in case of papillary thyroid carcinoma or not? So this was the aim of our work, is to determine the incidence of level 1 affection or involvement of cervical lymph nodes, especially those with involved level 2. Of course, level 2 because it is in the close vicinity of the level 1. As you know, all know the different types of thyroid cancer. We excluded all the others. The study included only patients with papillary thyroid carcinoma, about 30 patients with level stage N1B. In 24 patients, the disease was unilateral, but in 6, the lymph nodes was bilateral. Preoperative assessment, of course, was done with history taking and clinical examination, all the laboratory tests and the imaging, the ultrasound, the CT of the neck, and all patients were subjected to modified radical neck dissection, including all levels of the neck, to see the instance of the involvement of level 1. And of course, preoperatively, the pathology was done. Along with total thyroidectomy, of course, the type of neck dissection was performed. And as we said before, level 1 was dissected and labeled in all cases. So what were the results that we had? The age ranged between 12 and 74 with the mean age of 46 years. Males were more affected than females, slightly less than females, but almost equal. 14 patients were above the age of 45, which is almost half of the cases. The main complaint was a lateral neck mass. And some patients had history of thyroidectomy, like hemithyroidectomy, subtotal, total even thyroidectomy. And regarding the family history, only 5 patients had history of benign thyroid disease. Only 3 patients had family history of malignant thyroid disease. I will not go into the details of the sensitivity and imaging and so on. So the surgical procedures that were done were total thyroidectomy, completion thyroidectomy of both lobes or of the right or left lobes. The neck sides that were dissected were, as we said, 6 patients were bilateral neck dissection, while the others were unilateral, 14 on the right side and 10 on the left side. We had some temporary complications of hypocalcemia, nerve complications, and voice complications, but these were all temporary in most of the cases. The post-operative assessment, as we said, the left vocal cord was sluggish mobility in only 1 patient, and the right vocal cord is sluggish mobility in 3 patients. So since our study involved the patients with level 2 lymph nodes, about half of the patients had level 2 lymph nodes involved, which is the upper deep cervical. And the level 1 was involved in 5 patients out of the 36 sites, accounting for about 14%. So what are the predictors of involvement of level 1? Now we can see that in 6 patients, only 1 level of lymph nodes was affected. In 10 patients, 2 levels or 3 levels were affected, and so on. So when the 3 levels or more of the lymph nodes were affected, there was a higher instance of affection of level 1. These are the post-operative histological results. It were well differentiated in 15, multifocal variant in 5, and then microcarcinoma encapsulated and so on. So the affection or the involvement of level 1 in cases of level 2. And out of the 5 patients with involved level 1, 3 had level 2 involvement, and 2 had did not have a level 2 involvement. How can I get rid of this? So regarding the other factors like the age, duration of symptoms, the size of the largest lymph node, the size of the nodule in the lymph node, the gender, and the family history of thyroid cancer and the histopathology, they all had no relation with involvement of level 1 lymph nodes. Even the type of radical neck dissection, however, the number of levels affected was significantly related to the level 1 involvement. If 3 levels or more of the cervical lymph nodes were involved, then it is expected that level 1 would also be involved. So the factors that were related were the multiple levels and invasion of the neck structures, but not with the other neck levels or age or gender or duration of symptoms or family history or size of the nodule or size of the gland or size of the lymph nodes or even the histopathological variant. So what do we conclude from this? That though not uncommon in patients with papillary thyroid carcinoma, the involvement of level 1 is not related to involvement of level 2, which is the closest group, or any other variable, other than the involvement of the surrounding structures outside the thyroid confinement and the multiple levels 3 or more of the levels in the neck. So since high-risk patients with papillary thyroid carcinoma need aggressive treatment to improve their prognosis in terms of survival and reduction and recurrence, level 1 dissection is recommended only in those patients with multi-level disease, 3 levels or more, or with invasion of the important neck structures like the spinal accessory nerve, the sternocleidomastoid muscle, or the internal jugular lymph nodes. Thank you very much.
Yeah, thank you very much. I mean, just a very simple one. I was just wondering why it was only the papillary thyroid tumors that you...
Because they are the type that spreads by lymphatics. It spreads to the cervical lymph nodes, but the other variants, they go through the bloodstream to the lungs and other structures. Thank you.
What about there is a post-operative therapy?
Yes, we send the patients to the to the medical oncology department, but usually the L-toxin is not started, the replacement therapy, unless we know the exact pathology. Because if they're going to need post-operative therapy with radioactive iodine, then the L-toxin should be stopped 2 or 3 weeks before the starting the medication.